Hi, my name is Emily, and today we're going to be doing a cardiac and respiratory evaluation. And I'm a family nurse practitioner student. If you want to say your name and date of birth.
Jordan Gross, 5/26/96.
And can you tell me where you are?
I'm in Mount Pleasant.
And what is the date today?
Saturday, February 21st, 2026.
Perfect. So to start our exam, we're going to start with jugular venous pressure. To do this exam, I'm going to have the patient face the opposite way of where I'm standing, and I'm going to pretend that I'm using tangential lighting. I also have the patient angled at a 30 to 45 degree angle. Unfortunately, I don't have a chair that does that, so we're just going to pretend. And then I'm inspecting between the sternocleidomastoid muscle, looking for any internal jugular pulsation. So I'm going to go ahead on this side. I would have my tangential lighting in my hand. And if you want to look a little bit towards your left, yeah. And I'd be looking on this side. And then if you want to look towards the right, with my lighting again. And there's no visible jugular distension at 30 to 45 degrees, and it was less than 3 centimeters above the sternal angle. So now we're going to go on to the carotid arteries. So just again, looking for any visible pulsations, which I do not see on either side. So now we're going to go ahead and palpate. So just taking 2 fingers, going about 1/3 of the way down, making sure to do one side at a time. Good. This side. And carotid pulses are 2+, equal, and bilaterally. So now we're going to go on to just the anterior thoracic chest. Just upon looking at the chest and looking at the patient, you can start assessing respiratory rate, rhythm, depth, any use of accessory muscles or retractions. Looking at him, he has nice, normal, even breathing, unlabored respirations. There's no accessory muscles being used. We can also assess his AP to transverse diameter. If you want to go ahead and sit up straight for me. Yeah. So we can say he has a nice 1-to-2 ratio. He's normal, young, healthy. Doesn't have any like barrel chest, which would be a 1-to-1. So now I'm going to go ahead and palpate his interior chest. We're palpating for tenderness, masses, any crepitus. So is it okay if I go ahead and feel your chest?
Yeah.
Okay. So again, just feeling for any of those masses or tenderness or crepitus. Any pain?
No.
Okay. So there's no masses, crepitus, or any tenderness in his chest. So now we're going to go on to auscultate. So for this, we want to make sure we're listening to both sides for a full inhale and exhale. We're assessing for vesicular versus bronchial sounds, trying to listen for any adventitious sounds like bronchi, wheezing, any rubs. Obviously, it is best to do this with a bare chest, but just for privacy purposes, we are going to keep the shirt on today. And then I just need you to take normal inhales and exhales and just try not to move too much, okay? So just going to listen to your lungs right now. And lung sounds are clear bilaterally, and I don't hear any adventitious sounds. So now we're going to go on to locate the sternal angle and angle of Louis. So to do this, we're going to start by, sit back, yeah. We're going to start by trying to palpate the jugular notch, which is right here. We're going to go down to the second rib, to the sternal angle, and then we're going to slide to the intercostal space right there. So that's where that would be. We're also going to inspect the pericardium for any lifts or heaves or visible pulsations, which I do not see on him. So now we're going to go ahead and palpate the point of maximum impulse. For this one, I'm going to start by finding his 5th rib. Right here. And then we're going to slide over to the intercostal space and the midclavicular line. And his PMI is palpated at the 5th intercostal space at the midclavicular line. It's about 2 centimeters in diameter. If I wasn't able to find it in this position, or if the patient had a bigger BMI, or larger BMI I should say, we could put him in a left lateral decubitus position, and that might be a little bit better way to palpate that. So now we're going to go on to the auscultation of the heart sounds, but we'll go over those really quick first. So starting with the valves, we have the aortic, which is at the 2nd intercostal space on the right. We We have the pulmonic, which is the second intercostal space on the left. We have the herbs, which is the third intercostal space on the left. Tricuspid, which is the fourth and fifth intercostal space on the left. And then mitral, which is the fifth intercostal space at the midclavicular line. We're also going to assess for S1. We can hear that mostly during tricuspid and mitral valve closure. We're going to assess for S2, which we can hear during aortic and pulmonic valve closure. We're going to assess for S3 and S4 and any murmurs as well. So I'm just going to go ahead and listen to your heart if that's okay. So go down to the second register. And S1 and S2 were present, and there was no extra heart sounds or any murmurs. I would also, if I did hear any murmurs though, I want to know if it was systolic or diastolic. I want to try to rate intensity on a scale of 1 to 6. I'd also want to go over location, quality, radiation, pitch, if I'm able to assess those as well. So now we're going to go on to the thoracic chest. So I'm going to actually have you stand up, and I'm going to switch over to this bench. Move this chair. Okay, so we're going to go ahead and move this bench right here. Yep, and then if you want to go ahead and actually face this way, yeah. So just upon looking at the thoracic chest, automatically we can assess for symmetry. We can look for any scoliosis, kyphosis, any deformities. There's none of those noted, and his thoracic chest does look symmetric. We're going to go on and also to his posterior chest as well. Again, listening for any adventitious sounds. So same thing as before, just listen to those lungs. Just take normal inhales and exhales. And his breath sounds are clear bilaterally again, and I don't hear any adventitious sounds. So now we're going to go ahead on and do the voice sounds. So we're going to start off with the whispered pectoraloquy. For this one, I'm going to have the patient whisper 1, 2, 3, and every time I move my stethoscope, he'll whisper 1, 2, 3 again. So I'm going to put my stethoscope in, and every time I move it, you'll whisper 1, 2, 3, 1, 2, 3. Okay? All right, you ready? And there's no increase in intensity or consolidation. So now we're going to go on to egophony, and for this one, I'm going to have the patient say E every time I move my stethoscope. So just wait till I move it to start saying it, okay? All right, ready? So E.
E.
Again.
E. 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 E.
And there was no increase in intensity or in consolidation. When doing that, if it started to sound more like ah in my ears, that would be abnormal. So for our last one, we're going to do bronchophony, and for this one, the patient's going to say 99. So same thing as before, just say 99 every time I move my stethoscope.
99. 99. 99. 99. 99. 99. 99. 99.
And there was no increase in intensity or in consolidation. If it was for some reason loud and really clear, I was able to hear that 99, that would be abnormal. So there's no normal transmission of sounds or voice sounds in my patient today. So now we're gonna go on to posterior palpation. So same thing as before, just palpating for any masses or crepitus, any tenderness. So I'm gonna go ahead and touch your back if that's okay.
Okay.
Any tenderness as I'm touching?
Mm-mm.
I'm not feeling any masses or crepitus. I'm also going to do tactile phragmitis. So for this one, I'm going to place both of my hands on each patient's side, on both sides. As the patient says 99, I'm just going down to make sure it feels symmetric. So every time I move my hands, we'll say 99,
Okay.
99, 99. Go ahead.
99, 99, 99, 99, 99.
Good. And that was symmetric. Next one we're going to do is thoracic expansion. So again, placing my hands at T9 and T10. When he does a big inhale and exhale, making sure that goes up symmetrically. So just going to place my hands right here, and then I'll have you take a big inhale and just let it out. Good. And there was symmetric expansion. So now we're going to go on to percussion. We're going to do that posteriorly and laterally. So just going in, making sure we're at the intercostal space. We're going to percuss. And the sound is resonant. Now we're going to go on to diaphragmatic excursion. So for this, we're going to percuss down during quiet breathing from the level of resonance, which is the scapula, to the level of dullness, which is the midclavicular line. So first, I'm just going to try to find his scapulas. Go ahead and kind of like round your shoulders a little. Yeah, so I can feel it. Good. So right here. And then just normal breathing for me. Level of dullness to the side. There. So now I'm going to have the patient take a big inhale, and for this one we're going to mark dullness as the inferior layer of the diaphragm. So for this one, whenever you're ready, you're going to take a big inhale and you're going to hold that. Okay. Let me just find your scapula first. Okay. And whenever you're ready. So right here, and relax. So normally I would take my pen and I'd mark this spot on the patient's back. We aren't going to mark his shirt though, so we're just going to pretend. So now I'm going to have him do a big inhale and take an exhale, and he's going to hold that exhale, and then I'll mark again at the layer of resonance. So whenever you're ready, take a big inhale and then exhale and hold that. Go ahead and hold that. So right there. So I will go ahead and mark that. You can relax. And as long as that is within 3 to 5 centimeters, that'll be within normal. I would go ahead and do the other side, but I'm not going to make him keep holding his breath. But I would do the other side as well. Okay. If you want to go ahead and face forward. So now we're going to move on to peripheral pulses. So we're going to be doing his radial, brachial, posterior tibial, and doralis pedis. Just assessing his rate, rhythm, and amplitude. So I'll start with your radial holding. Good, and we'll do brachial as well. You can go ahead and straighten your arms a little bit. Yeah. There you go. And those are both 2+ bilaterally. So we have his lower extremities, we want to figure, yeah, just like that. So we'll start with his posterior tibial. And those are also both 2+ bilaterally. So now we're going to go ahead and do cap refill. We'll do his fingers and his toes. So go ahead and put your fingers out like this. And just looking at your fingers. And do your toes as well if you guys want to like lift your toes a little bit. Yeah. And go those are both less than 2 seconds. So now we're going to go on and assess for arterial insufficiency. We'll go over those 6 P's. So for pain, we'll just ask the patient, any sudden leg pain?
No.
Okay, good. For pallor, we're looking at the color of his legs. They're nice and pink and warm, or nice and pink. For poikilotherma, we're just feeling his legs. They're nice and warm, both sides. For paresthesia, we'd ask the patient, any numbness or tingling in your legs? Good. And then for paralysis, we'll have the patient wiggle his toes. Yep. And then if you want to flex your toes up like this, and then go ahead and point them down. Good. And then for pulselessness, we just palpated his pulses on his feet. We know those were 2+. So we can say his extremities are warm, pink, sensation was intact, strength 5 out of 5, and pulses were 2+ bilaterally. So now we're going to go on to palpate for edema. So we're going to do his pretibial and his medial malleolus. So going to the pretibial area, just assessing for any pitting edema on both legs. Over the medial malleolus. And there's no pitting edema present. If there was any edema, we want to grade it from 1+ to 4+. Now we're just going to quickly go over arterial versus venous disease. So for arterial, things we would see in the legs would be coolness, paleness, pulselessness, shiny skin, hair loss. And then for venous, we'd see warm, edema, any brown discoloration, and aching. And that's it for my assessment.